Oh, it says recording. Does that mean we're recording?
We are recording.
I think so.
We are live.
Amazing. And very, very, very excited to be joined by the incredible Dr. Daneshmand from the San Diego Fertility Center, the genius that is, well, otherwise known as Dr. D to us, right?
Yes, yes. Thank you so much for this opportunity to be with you today.
We're very impressed by the certificates in the back of shot.
Well, yeah, I mean, this is like, one of those things you can buy on Zoom, so you can have that background with the diplomas.
I am definitely one of those.
You're actually sat in your kitchen, really.
I like to be surrounded by diplomas, so even at my house.
Well, we were hoping today we could basically pick your brains, and we have got a list of frequently asked questions. And we've got quite a few, so myself and Tracy have basically split them up, so we'll just fire them at you over the next half an hour or so, if that's okay with you.
That's great with me.
And also we probably should just say that, but neither myself nor Tracy ever have very good internet, because we live in really rubbish areas, so bear with us if we suddenly pause or freeze. That's the reason why.
I can tell you one thing, you're not going to get sponsored by BT, I tell you that much.
No.
I know they're definitely on lockdown at the moment.
So
should we just start firing through some questions? I've got a
absolutely.
great...
I think we could start with the questions, and I'm happy to answer them for your audience.
Oh my gosh, amazing. Well, the first one is very much like the first question that you would ask, and that is, what do you do first if you are just not getting pregnant naturally? What should you do?
And that's a great question. Essentially, we talk about the fact that if you're under the age of 35 and you've been having unprotected intercourse, not even paying attention to when you're ovulating, just having unprotected intercourse for 1 year, and you haven't been pregnant, then it's time to see a specialist. If you're 35 and older, then that period is 6 months. And the reason for that is because the number and the quality of the eggs in the ovary start to decline more rapidly at age 35. So we don't want to wait too long before the quality of the eggs decline further, and then it becomes sort of more difficult to get pregnant, even with fertility treatment. So under 35, 1 year, over 35, 6 months, and that's just, again, having unprotected intercourse. Now, why is that? That's because if all the systems are working fine, then after 6 months, about 75% of couples should be pregnant, not even paying attention to when they're having intercourse. And by 1 year, it's over 85%. And that's the reason why, again, we want to see patients after those periods of time.
See, I left mine 2 years. I wish I'd listened to you a long, long time ago.
Well, I think, but that inspired you, Sarah, to do what you're doing now, which is helping inform your audience, inform patients who are struggling with infertility. Yeah. I think information is the power that enables. Yes. And I think if patients understand that if they're struggling with infertility, that they really need to seek a specialist after a certain period of time, then they're empowered. And again, the initial phase of the investigation is some diagnostic testing. And there's sort of 4 pillars of the diagnostic testing are, we want to look at egg quality and egg count. We want to look at the sperm quality, sperm concentration, sperm quality. We want to make sure that the fallopian tubes are open, and we want to make sure the uterus doesn't have any abnormalities. So those 4 structures and 4 analyses are really important in investigating further as to why someone's not getting pregnant.
And I suppose because a lot of people think that immediately they're going to be told they need to have IVF, but that isn't the case, is it? As those tests might reveal that there are other ways that you can,
Absolutely. I mean, sometimes it could be a fibroid, a benign tumor inside the uterus that can be surgically removed. Sometimes it could be a situation with the sperm where the motility is low. And all that's needed is just intrauterine insemination, where the sperm is concentrated and injected into the uterus so that it gets closer to the fallopian tubes and the eggs. So there are many fertility treatments and steps other than in vitro fertilization that will help patients achieve a pregnancy. Sometimes it's just a lack of ovulation. For example, 4 to 7% of all reproductive age women suffer from polycystic ovary syndrome, which is this syndrome of irregular periods, sometimes associated with a higher risk of diabetes. And those particular patients just need a medication, a pill, to make them ovulate. And then they can just have timed intercourse right around the time of ovulation to achieve a pregnancy. So there's so many different treatment modalities that would help patients achieve a pregnancy other than in vitro fertilization. In vitro fertilization is done when we have sort of ruled out other treatment options, or we feel that we don't really have a great deal of time to try other options because the quality of the eggs or the quality of the sperm is going to deteriorate, and then it's going to become much harder even with IVF to achieve a pregnancy.
And that, actually, that's, yeah, that next one.
No, absolutely. But I was also just going to say that for me, it took me 10 years to get pregnant, and don't make the mistake that I did. Anyone watching, because for me it took 9 years to have tests, and those tests basically found that I had endometriosis, a blocked tube, a thyroid problem, and a polyp. And my husband also had a slight issue, and those 5 issues that were dealt with 9 years down the line. And then I was very blessed to go on and have my twins. But please don't follow my route, because you can address it soonest, just like Dr. D just said. Now, the next question we've got here is, how long from start to finish does a round of IVF take?
So typically a round of IVF takes about 3 weeks from start to finish. Now, that's if you perform a fresh embryo transfer. If you perform a frozen embryo transfer, then the IVF cycle is sort of divided into 2 parts, meaning that the first part takes about 2 weeks, where the ovaries are stimulated with medications, the same hormones that the brain produces. Those hormones will mature and develop eggs in the ovaries over the course of about 10 to 12 days. And then on the 12th to 14th day, the eggs are retrieved, fertilized with the sperm, and then it takes about 5 to 6 days for the embryos to develop to a stage called the blastocyst stage. And at that stage, the doctor has to make a decision. And the decision is, do you transfer the embryo fresh if the uterus is receptive? Or do you freeze the embryos and then wait until next month and prepare the uterus, make sure it is receptive before you transfer the embryo? Now, that's a critical sort of a decision tree. And the reason for that is because many years ago, we published a series of randomized controlled studies, published studies. And these studies showed that in the majority of patients who go through IVF, because of all the hormones that the uterus is exposed to during the IVF cycle, when we stimulate the ovaries produce all kinds of hormones, estrogen, progesterone, testosterone. Those hormones can have a negative impact on the receptivity of the uterus and make the uterus less receptive. So if we have a really good quality embryo, when we transfer it to a non-receptive uterus, it's not going to implant. And many years ago, I noticed that I was transferring really good quality embryos to the uterus, and we were not achieving a pregnancy, or there was a pregnancy, but it was an early pregnancy loss or a miscarriage. And all the years of practice, and I've been in practice now for 22 years, we were more embryocentric, meaning that if the embryo doesn't attach, it must be the embryo. But then what we did was we shifted gears, we pivoted, and we said, okay, maybe we should look at the uterus as the culprit here in regards to lack of receptivity. So what we did was we said, okay, we're going to have these embryos that are good quality. Let's freeze them, and let's not transfer them right away. Let's wait and make the uterus receptive the next month, because the next month the ovaries are quiet, they're not producing any hormones. We control what hormones the uterus sees, make the uterus receptive, and then transfer the embryos. So we did a series of randomized controlled trials, and we basically compared fresh versus frozen embryo transfers. in both randomized controlled trials, which were actually the first of their kind, the frozen arm had a better success rate than the fresh.
Wow.
And in fact, if you look at the SART database, which is the Society of American Reproductive Technologies, that they keep tabs on all the IVF cycles in the United States, right around the time of the publication of our papers, and then of course, subsequently, other researchers confirmed our theory. What ended up happening is the number of frozen embryo transfers in the United States started to rise. And now the number of frozen embryo transfers outnumbers the fresh transfers to a significant degree. Why? Because on many occasions during IVF, the fresh embryo transfer is not going to yield a very high pregnancy rates because the uterus is not receptive. So that's a really, really important sort of a decision that the doctor has to make, and it has to be based on science, based on published research and studies. I hear patients sometimes having pregnancy losses from IVF, or IVF not working. And again, what I do is I try to play detective, review all their medical records and see, okay, what aspect of their IVF cycle can we improve upon? And oftentimes it's the receptivity of the uterus. If we make the uterus receptive and if the embryo is healthy, then we're going to achieve a healthy pregnancy.
And if your clinic doesn't do that, or can you as a patient actually request that, or you know?
Well, I think if your clinic, if your doctor is not up to date with the latest research and publications, then I think it may be time to change your doctor.
Yeah.
Because it's not a matter of, I don't think patients should be requesting one treatment to the other. I see these ads on TV for different drugs. And you know, the ads, at least in the United States, say, ask your doctor if this medication is good for you. Well, I think the doctor should be up to date on all the latest research and studies, and a doctor should be recommending that, not a patient requesting it. I think that patients need to be informed, patients need to be updated on the latest research, on the studies. And one of the things I always tell patients is that if I'm recommending a certain route, or route, as you would say, in terms of your IVF treatment, then I need to prove to you through research that this is the route that's going to give you the best chance of pregnancy. So if I say, you know, it's better to do a frozen embryo transfer than a fresh, your question should be, why is that? And can you give me evidence of that? And I should be able to, as a doctor, give you evidence, research studies, maybe give you some follow-up material to read. So I do think that patients, you raise a good point, Sarah, and that is that it's not so much patients should request one type of treatment or the other, but they should question when doctors recommend one type of treatment or the other. They should not be shy about asking very specific questions. Why are you treating me this way? Why is this medication better than the other? Yes. And I think their due diligence is going to help them. If you're proactive with your treatment, I think you'll have a higher success.
Mm-hmm. I asked because during my light's gone off. Sorry. During my treatment, I don't think I asked the question why or what until my very last round. So I, you know, I had IUIs, I had IVF, none of which worked. And it was only when I was then told, okay, well, let's try ICSI. It was only then that I said, well, why have I had all the others? I didn't even know about ICSI. Right. So I sort of wish, you know, looking back, I'd sort of said before I had the IUI, well, hang on, do you know what I mean? I've heard about ICSI, just to have that knowledge, to be able to have that conversation with my doctor.
That's such a good point. That's a great point you raise. And there's so many different types of treatments and protocols that we employ in the field of IVF and the field of fertility treatment. And, you know, as a patient, you can't keep, you know, up to date. And even if you go to Dr. Google, you know, that information is not filtered. It's sometimes, you know, anecdotal stories about patients, you know, succeeding with one protocol versus the other. It's hard to sift through that data and then come out and say, well, it looks like this is the best treatment for me. But, you know, you have to rely on your fertility specialist, and your fertility specialist has to rely on the research data and information in order to be able to guide you.
Yeah. At the end of the day, choose a good clinic.
Yes.
And
Yes.
trust.
Yes. And, you know, and that's a great point, Sarah. It's like, how do you choose a good clinic? Well, you know, you can research the clinic, you can research the doctor in particular, their background, whether they're involved in research, whether they publish papers, they present research papers. So there are some ways in which patients can do their due diligence before they pick a fertility specialist.
Okay, so we have another question here. Sorry, did you want to go?
No, go. Honestly, otherwise we'll go forever if I keep asking.
So we have another question, which is, I have a low AMH level. Can I still get pregnant?
Absolutely. And AMH is a hormone that stands for anti-Müllerian hormone. It's secreted by these cells around the eggs called the granulosa cells. So it correlates with the number of eggs in your ovaries. So when the AMH levels are high, that means there's a high number of eggs in the ovaries. The pool of eggs is high. When it drops, it means there's less and less of eggs in the ovaries. Now remember, the women are born with all the eggs they're going to have in the ovaries, about 1 million at birth. By the time they start having periods around the time of puberty, they're down to about 400,000. And thereafter, every month they lose somewhere around 500 to 700, 500 to 1,000 eggs each month. So the AMH over time will start to decrease. AMH is an indication of the pool of eggs in the ovaries. Once it drops below a certain point, we do get concerned that both the number and the quality of the eggs in the ovaries is sort of taken a turn for its more significant decline. And those patients, we want to be proactive in terms of starting their treatment sooner. So you can still get pregnant, but you really need to be proactive and see your specialist much sooner if your AMH levels are low, because there comes a point where patients can run out of good quality eggs in the ovaries, and even fertility treatment like IVF won't be successful.
And what about egg quality? Can you improve your egg quality?
That's a great question. And we don't know if there's anything patients can do in terms of medication-wise to improve egg quality. But we do know there are some factors that can hamper or decrease egg quality. You know, smoking, for example, lack of exercise, poor nutrition, excessive drinking. Those are some of the factors that can be harmful to the eggs. And so whilst there are no specific medications that can enhance the quality of the eggs based on research, I think what patients can do is by keeping themselves in good health in terms of nutrition, sleep, exercise, not smoking, not excessively drinking, all of those factors, those can at least kind of stem the decline of the quality of the eggs in the ovaries. Now, there are some studies, animal studies, that show perhaps some supplements like coenzyme Q10, potentially DHEA, may help with in some cycles of in vitro fertilization in terms of some minor improvement of the quality of the eggs. The research in those areas is not foolproof. It's not a sort of high quality research. So I do think that patients should talk to their fertility specialists. They should analyze the AMH level, the quality of the eggs, and then make the best sort of path for them in terms of fertility treatment. But be careful, be wary of people who sell products that say, well, if you take this, it's going to really enhance the quality of your eggs. There's really no such thing out there. Mm-hmm. If there was, we would be handing them out at the door as patients came in, because we want our patients to achieve a pregnancy. And of course, egg quality is one of the most important factors in determining the success rate of fertility treatments that we perform, in particular IVF.
So it's more about stopping the decline of the quality as opposed to trying to bring
Exactly right. Exactly right.
And that kind of goes into this question, which was, what can I be doing prior to treatment to enhance my chances of success? Or is it really just down to luck?
Well, it's not so much luck. I mean, what you can do is you can sort of make sure you pay heed to the sort of the pillars of health, which are sleep, nutrition, and exercise. I think if you can get good sleep and you eat well in terms of your nutrition and you exercise on a regular basis, those are some of the things that you can do in order to get yourself in the best shape possible for possible future fertility treatment and your pregnancy. Because if you're in really good physical shape, you reduce the risk of complications during your pregnancy, reduce the risk of miscarriage, reduce the risk of diabetes, high blood pressure, all of those complications that occur in pregnancy. Many women suffer from miscarriages because of the fact that the blood sugar is high in the first trimester. When the blood sugar is high in the first trimester, that increases the risk of genetic malformations with the fetus, in particular just what we call malformations, and that can increase the risk of miscarriage. So all of those factors in terms of nutrition, exercise, sleep, not smoking, has an impact on not only improving the quality of the sperm and the eggs, but also minimizing the chance of, or reducing the chance of complications like gestational diabetes during pregnancy.
So again, I wish I'd done all of that before mine. I've said before that my husband used to be in a rock band, so he was not preparing at all. You know? He was on tour on the year that I decided we should have a baby. So, you know, he had a base strapped to his groin, you know, and so
not ideal conditions.
Yeah. Never once did we think, perhaps we should make some lifestyle changes.
It's hard. I mean, it's hard to make those lifestyle changes. I know that, you know, for patients who smoke, you know, stopping smoking is difficult. Also, in terms of nutrition and exercise, it's not easy. It's difficult, but I do think that you have to be proactive with your own health in order to be able to maximize your chance of success of having a healthy pregnancy.
Yeah. I think it also makes you feel more in control if you feel as though you're doing everything you possibly can.
Absolutely.
Essentially, you're then giving your body over to the doctors. So if you can give it to them,
right,
the best that it can be, you're like, well, I've done what I can do, you know?
Exactly. And, you know, in the best of circumstances, this is a team effort. You know, the patient, the doctor, the nurse, the team at the fertility center, all of the team members have to support one another in order for the patient to achieve a successful pregnancy, a healthy pregnancy. And I think a supportive team at the clinic with the specialist is really invaluable when it comes to supporting and guiding patients through this period of treatment, you know, because when you look at something like in vitro fertilization, it's physically, it's emotionally, it's financially a difficult process to go through. And the more support you can get from your doctors, from the nurses, from the team at the fertility center, the more successful you become. So when we have a discussion, when I have an initial consultation with patients, you know, we go through everything, but one thing in particular we go through is, you know, this is I need your help in order for you to achieve a successful pregnancy. We're a team now, and it's not about, oh, it's a sperm factor, so it's his problem, or it's an egg factor, it's her problem. No, this is a team, and our goal is to achieve a healthy pregnancy. So we were going to work as a team to help one another, and in order to be able to have you reach your goal of becoming parents.
That sounds so lovely.
Well,
and it works. It works. You know, the patients who sort of what we call in the United States, you kind of buy into that philosophy, really feel that they're more empowered, that they feel like they're contributing to what's happening. It's not just a doctor telling them, okay, do A, B, C, D, then come back on this day. No, it's this constant communication and back and forth and support. And I think that the fertility team has to be available to the patient all the time. I mean, I see my patients when they get blood work and ultrasounds, you know, I call them up, I let them know, you know, how things are going, what they can do to improve the ultimate success of their treatment. It's a constant communication and support. And I think that's the ideal way of going through this sort of stressful journey of fertility treatment.
Absolutely. Right, what's next on the list, T?
Okay, so the next is the guys. So male infertility or male fertility. So we have a question here: can I improve the quality of my sperm?
Well, again, all of the factors we talked about, egg quality, apply to sperm quality. You know, smoking, excessive drinking, lack of exercise, poor nutrition, all of those things can reduce sperm quality. Now, the one advantage that men have is that men continuously produce sperm throughout their life, well into the 50s and 60s and beyond. Now, whilst the quality of that sperm does decline in the late 40s and 50s, oftentimes it's not to the point where it has a significant impact on the ability to achieve a pregnancy. But men can have fertility problems with their sperm in one of two ways. Well, more than one of two ways, but if you look at the two most common ways. Number one, there are genetic factors. So you see young men, old men have abnormalities in the morphology of the sperm and motility and the counts. And we feel that those are genetically related to probably the Y chromosome. There may be some micro deletions. In fact, there are some that have been identified, mutations, deletions on the Y chromosome that can lead to abnormal production of sperm. So that's one issue. Another issue could be related to lifestyle factors, environmental factors. If men, again, have smoke on a regular basis, excessive drinking, if they've been through chemotherapy, if they've been through a particular treatment that is toxic to the sperm, those are other types of abnormalities of the sperm. And then you also have some mechanical or anatomic factors that can affect sperm. It doesn't affect sperm production, but it affects the ability of the sperm to make it all the way out. So those are what we call obstructive factors. There's some obstruction in sort of the pipeline from the sperm getting to the outside into the semen, and that needs to be investigated. So when we do a sperm analysis, we look at many, many different parameters. We look at the volume, we look at the count, the motility, the morphology, many parameters. And based on that sperm analysis, that gives the fertility doctor lots of information as to, okay, what's going on here and what areas are contributing to fertility problems. Now, there are some studies that show that in men who have some abnormal sperm parameters, that sometimes antioxidants can help. Because sometimes in the male reproductive tract, there are these oxygen radicals that can cause problems with sperm production and also the morphology of the sperm. So there's some data showing that if we use antioxidants, what are antioxidants? Vitamin C, zinc, folic acid, L-carnitine. These are some antioxidants that potentially could help cause some minor improvements in sperm quality. And so for men who have these either borderline levels of sperm or who have abnormalities, I typically recommend antioxidants. They're just vitamins and antioxidants, and so it's not a significant burden. And usually I'll outline exactly the dosage I want men on. And typically we want them on for about maybe 2 months, 2.5 months. So we go through a sperm cycle in order to see if we can get some minor improvement. The other thing is, the good news is that with sperm, even when there are significant abnormalities, there are things that we can do to overcome it. You mentioned, Sarah, ICSI. It's a protocol where we take individual sperm injected inside the eggs. We also now have other modalities. Just recently, just several weeks ago, a great paper was presented at the American Society of Reproductive Medicine conference. We were presenting our research papers there. There was another great center that would presented a paper on something called the Zymote protocol, which is a protocol in which we've been using for about a couple of years. And it's a way to essentially select out the highest quality DNA sperm. And then from those particular group of high quality DNA sperm, we can take individual sperm and fertilize the eggs. So I do think that not enough attention has been paid to the sperm. And I do think that sometimes miscarriages, fertility problems, unsuccessful IVF cycles are because the sperm and not the eggs in a significant portion of patients. percentage of patients. So I do think that we have to concentrate on both egg quality and sperm quality if we want to achieve a healthy pregnancy.
And what are your thoughts on tight underpants?
I don't feel
I'm not personally.
You know, I have not seen a higher level of infertility in Italian men versus other. So I don't think that tight underpants really have any impact. I think that's an urban myth. You know, the French call it the légende urbaine. So it's just an urban myth. You know, cycling, tight underpants. I think there's no evidence. In fact, there is a study out of a university called the University of Southern California, and they actually looked at these sort of boxers type pants. They didn't really see any difference in terms of sperm quality, sperm count. So if you're comfortable in tight underpants, then be my guest.
Now we've got a question here about at what point do you realize that sperm donation is your only option?
I think sperm donation becomes an option if, you know, all the modalities we discussed just don't yield any sperm. In other words, a man comes into the fertility specialist's office to give a sperm analysis. You look at the sperm analysis, there are no sperm. Then you have to investigate, is this an obstruction? So men who are not producing any sperm in the testicles, that's when sperm donation becomes an option. But in the majority of instances, sperm is being produced, but it may be produced at a very low level within the testicles. So we actually can go in and get the sperm directly from the testicles and then use that sperm in vitro fertilization. You can't use it in insemination because you're not going to get millions of sperm. You're going to get hundreds of sperm, but that still can achieve a pregnancy in vitro fertilization. So, you know, that's called a testicular sperm extraction, testicular sperm aspiration. So there are all these techniques where we can extract sperm from the testicles, even in men that have no sperm in their ejaculate. It doesn't mean that necessarily that they're not producing sperm in the testicles. So really an investigation has to be made. There's a whole series of investigation, meaning blood hormone levels, sometimes an ultrasound of the testicles, the sperm parameters. It takes investigation. And if all those roads sort of don't lead to sperm being able to be extracted from the testicle, then that's when sperm donation becomes an option. But in the majority of instances, we can find sperm in the testicles. It's just at very low numbers. That's why when you look at it in the semen, you don't see any sperm.
We had an email recently from a man who was told that, you know, sperm donation was the only option for him and his wife to have a child, and he was struggling really, really, really hard with that. Right. It just couldn't get his head around it, and so we connected him with a counsellor that is he's dealing with it now, but it just was a complete barrier, and so everything sort of came to a halt. So do you, when that happens and you know, on the occasions where you have to tell a couple or, you know, a guy that it's just not going to happen with his own sperm, do you then provide counseling, or do you do that yourself? How do you?
I gauge the need of the patient. I think if the patients are struggling with that decision, I think if they're just, and I have many patients right now, I offer them the counseling. You know, we have counselors on our team, and we certainly offer that to them. Sometimes they're not ready. Sometimes they just want to talk to me, and sometimes after our discussions, they decide, okay, yeah, this is probably the best route for me. They have private discussions together, and then they come back and say, yes, you know, it looks like we're gonna go forward with a sperm donor. But you raise a very good point, and that is that you know, I think counselors play an important and pivotal role in helping support patients with these types of decisions, helping them support them even, you know, through the fertility struggles that they have. So I am always available for patients to discuss these issues with. Counselors are also invaluable to support and guide them as well.
And again, that's something I never did. Did you have counselling, T?
No, not at all. Not at all. I think it probably would have been helpful, but no. What? Yeah, I mean, not enough people do. Not enough people do. I think it's very advisable.
And that's why.
Yeah.
Sorry,
I agree.
on.
I was going to say that's why, you know, your network, your program, and what you've built is really important, because it's really a support network for fertility patients as they go, you know, navigate, you know, their fertility journeys. They don't feel alone. There are many others who are struggling like them, and, you know, to be able to, you know, provide support for them and help them, you know, navigate this difficult time period in their lives. That's really important.
But, you know, we've even got readers that have, those that didn't have counselling, they've told us that they now have, it's called like the Scar of Infertility. So even though, you know, I've now got twins through IVF, but I still have these issues buried deep down. So when somebody tells me that they suddenly got pregnant naturally, something happens inside of me. I don't know. It's just this kind of, oh God, you know, that, well, I had to really struggle, and it's still buried in there. And it's because I never dealt with it. I never spoke about it. I just got on with it. And it has left a, you know, I'm blessed because I'm blessed. I know I'm very, very lucky, but it is that scar of infertility, and it's,
yeah,
you know, it's.
No, absolutely. And, you know, someone who can help you gain awareness and insight into your feelings and what are the best ways in which you can tackle them or cope, you know, because, you know, throughout our lives, there are many times where we feel stressors. We feel stress, and I do think that speaking about them, gaining insight, and being able to develop sort of coping mechanisms for these stresses that we feel in our lives is really important. So I actually think that, especially now during this sort of period of somewhat isolation and, you know, restrictions, I think supporting one another, counseling, being more aware of the feelings that we are having, dealing with the stresses, you know, developing coping skills and mechanisms to deal with the stresses that we have is really critical. And it's critical as for growth of humans to be able to gain insight into these feelings and be more aware of them. If you're not aware of these feelings and you don't have insight, you can't bring them forth and deal with them and develop strategies to be able to make yourself feel better. Yeah. If they just stay within you. So again, that's the invaluable service that counselors provide. You know, I remember when I was back in medical school, you know, when we got to my psychiatry rotation, a lot of the medical students were saying, "Oh, it's now psychiatry rotation. It's a much easier rotation," and so because it wasn't surgery, it wasn't internal medicine, it wasn't the intensity, but it was very intense. In fact, it was more intense in many ways than the other rotations that I had psychiatry, because you sat down and you had to speak to your patients and you had to understand their vulnerabilities, you know, their anxieties, their feelings that they were having, and you came one-on-one, and then you had to help them develop coping skills, support them, guide them. By the time I would get home from medical school from my psychiatry rotation, I was just mentally drained. I said, this is actually the toughest, but the most enjoyable rotation I've had, because I feel like I'm potentially making a little difference in some people's lives.
You know, when, in terms of, you know, offering those coping skills, because IVF is not, you're not guaranteed it's going to work the first time, right? I mean, I don't actually know anyone who's had a successful first round, me personally. So when somebody comes to you, do you sort of almost prepare them for that, the fact that it might not work, so that they're almost armed with a kind of...
You know, what I do is I look at their history, I look at their hormone levels, I look at all the diagnostic testing that we've done. And then what I do is I say, okay, this is the chance of pregnancy when we go through IVF. This is based on your age, your hormone parameters, your AMH level, your cycle day 3 FSH level, the sperm parameters. This is what we expect. And patients say, well, Dr. D, it may not work, right? I said, yeah, it may not work. But, let's say you have a 70% chance of achieving a live birth with the treatment that we're going to pursue, but there's a 30% chance it may not work. And if it doesn't work, this is what we're going to do.
Yeah.
So we have a plan B in place, and if it doesn't work, and we'll be there for you. If it doesn't work, yes, we will. We're going to pull our sleeves up, and we're going to get back to work, and we're going to do everything possible to help you achieve your goal of becoming a parent. Whilst the chance of pregnancy is not 100% with any treatment, including in vitro fertilization, I do think the advances that have been made in the field really have pushed the pregnancy rates very, very high. When I started practice, I did my training at UCLA in Los Angeles, and we were practicing IVF back in the 1990s. I mean, the pregnancy rates were somewhere around maybe 20%, 20, 25%, even in good prognosis patients. Now, in the good prognosis patients, we're achieving pregnancy rates in the rate of 70 to 80%. It's still not 100%, but it's still a significant leap from where we were many years ago. So I do think there's a great deal of hope that for many patients, they will achieve pregnancy with the help of their fertility specialists, whether it's insemination, in vitro fertilization. And I tried everything I can do to make that happen within the first IVF cycle. It's hard to go through, cycle after cycle after cycle. So again, we want to get the conditions ideal so that we have the best chance of retrieving good quality eggs, having the best quality sperm. Everything has to be in place. So there's a lot of work to be done before a patient starts IVF, and there's a lot of work that's done during the IVF cycle. It's almost like you have to, sort of be the conductor, the captain of the ship, and there are certain nuances in vitro fertilization, and you have to manage all of them during the IVF. And the more meticulous you are, the more passionate and focused you are on those things, the higher the success rate for the patient. It's like, I think anything, the more you put into it, the more you're going to get out.
That sounds amazing. Absolutely amazing. Absolutely amazing. I think because I think I always feel like I put my clinic down, and I don't mean to. It's just I had IVF on the NHS in the UK, which is, the NHS is phenomenal.
They are.
And I have IVF for free, but you don't get the sort of nurturing that you do if you were to go to a private clinic. But, honestly, my doctor was amazing. But again, I don't think I ever had the chat that, this might not work. So I assumed it would. So when I had the call to say, look, this hasn't worked, I was just like, hang on.
I know. And I agree with you. I think even, whether it's private or NHS, and I lived in England for many, many years. Most of my family members still live in England. So I was one of the patients at the NHS for many years. I had really bad allergies growing up. And so would see an allergy specialist at the NHS, and, loved my care. And I was very fortunate to be able to have that option, NHS. We don't have a public option here in the United States. You do. You have the NHS that protects the lives and health care of your citizens and your people. We don't have that option. I think there's still a lot of things that we can learn from the United Kingdom. But again, it's one of those things where even whether it's a private or public or NHS, I think you just need to spend a little bit more time listening to patients and supporting them.
Yeah.
I just think we just try to go through our day very quickly and, rush through, okay, this is what your medication you take, and here I want you to take it at 5 o'clock in the afternoon and come back to, on Tuesday, we're going to do another scan, and that's it. Okay, goodbye. I just think that, taking a few more minutes to talk to the patient and seeing how he or she's feeling, I think it's a good thing.
Yeah.
Not only for their, sort of mental health as they go through treatment, but I do think that it may actually have an effect on success rates. I think that maybe having a positive attitude and having that support, I think sometimes helps. So I agree with you.
Actually, T said that about her successful round. Your vibe changed, didn't it, T? Your positivity.
Yeah, certainly the first time round, I had 2 IVFs. And the first time round, I didn't do anything. I just kind of went along with the process, didn't change my life, my lifestyle. Went straight back to work, straight after the transfer, and just carried on as if nothing had just happened. And it didn't work. Then the second time, a few years down the line, I did everything. I ate Chinese bark. Excuse me. I did everything. I burnt so many saucepans in trying to make these special Chinese potions, which made me feel very healthy, by the way. But yeah, I did everything. I did acupuncture, meditation, exercise. I just thought, throw everything at it. I've got nothing to lose.
Right.
And it worked. But, who knows whether that was part of it, but I certainly felt better through the process.
Right. And you felt more engaged in the process. You felt like you were being proactive. You were doing something.
And I thought, if it doesn't work, I can't look back and think I didn't try.
Yeah. No, absolutely.
And I had a super supportive consultant. He was just brilliant. And so, he was sort of managing me and I was trying to manage me as well. And so, yeah, very blessed that it worked. But
that's great.
I did actually have a few miscarriages in between those 2 IVFs. One of the questions here is about recurrent implantation failure. Why does this happen?
And that's a great question. So when we look at, there are 2 types of sort of diagnoses. One is recurrent pregnancy loss, meaning that patients who haven't seen a specialist yet, they have miscarriages, especially in the first trimester, sometimes the early second trimester. And we do a full workup on those patients. Oftentimes it could be something related to the egg, sometimes the sperm, sometimes the uterus. There could be some immunological factors, although we got to be very careful with expanding this immunological diagnosis. There's only really a very few immunological factors that can affect pregnancy and implantation. And so we have to do a workup. Now, recurrent implantation failure typically is something that's relates to the actual cycle of IVF. In other words, we're transferring embryos into the uterus and we're not getting implantation. The embryo is not implanting. Why is that? Well, and that typically is for one of 2 reasons. Either the embryo has chromosomal or genetic abnormalities and it's not attaching, or the uterus and the embryo are not synchronized, meaning that the uterus is just not receptive at the time when the embryo is transferred. And that's something we talked about before, fresh versus frozen embryo transfers. So we have to figure out exactly what the reason is that's causing implantation. Is it the embryo? Now, we can sometimes do chromosome testing on the embryos, genetic screening on the embryos to assess whether they carry any chromosomal copy abnormalities. That's not for everyone. It's for a select group of patients. And then the uterus, we talked about the fact that there are many research studies and there are ways in which we can make the uterus receptive. And then also to understand exactly the window of implantation. We call that window of implantation, the time period when the uterus is most receptive to accept the embryo to allow pregnancy to occur. And understanding the window of implantation and making sure the embryo is chromosomally normal and a good quality blastocyst, meaning a day 5 or 6 embryo, that's critical in terms of being to overcome implantation failure.
There's a test, isn't there? Is it the ERA test?
There's an ERA test that basically it's an endometrial receptivity assay. And it's really not something that has absolutely been proven to work for everyone. It may work for a small subset of patients, but not for everyone. So I do think that it's something that you need to speak to your specialist about in terms of whether the ERA biopsy is something that's going to be helpful. ERA is actually very innovative, uses innovative technology to look at all these particular factors in the uterus that are active or not active at the time of implantation. And based on those particular assays, they figure out, okay, the most receptive time of the uterus is this particular period of time. It's not for everyone. It shouldn't be applied sort of with a broad brush for every patient who has implantation failure or for every patient suffering from infertility. There are some specific cases where that may be indicated.
Okay. What else have we got on here? Oh yes. So okay. A bit like we asked earlier about sperm donation. At what point do you realize that egg donation is your only option? Like how many times do you need to fail before you are like, wow, okay, let's move on to the next?
I think there are two factors that are important. One is, okay, how many times have you gone through IVF and, without success? But the other issue is that what was the reason for the lack of success? Because egg donation only will address one issue, and that is the quality of the eggs. But what if the problem with the IVF cycle not working is not related to the egg quality? Maybe it's related to sperm quality. Maybe it's related to the uterus. Maybe the uterus is not receptive. For example, we used to, many years ago, transfer these good quality embryos. They wouldn't implant. We wouldn't get pregnancies. And so, you could think in that particular circumstance that somebody may say, well, maybe it's the embryos are not good quality, despite the fact that they look really good on the microscope. They're probably not. Maybe egg donation is the next step. But if you haven't solved the issue with endometrial receptivity, and then even going to egg donation, that's not going to work. There are many women who suffer from adenomyosis, other factors, fibroids, leiomyomatous uterus, factors in the uterus that are causing or preventing the embryo from implanting. You have to make sure that the reason is the egg quality. And if you've gone through a few cycles of IVF and the embryo quality is not good and the embryos are chromosomally abnormal, and all your, the hormone parameters, the FSH level, the AMH levels don't look very encouraging, that's a time when, the conversation about egg donation should be started. But you have to make sure that, you've addressed everything else, that really the true diagnosis is an egg quality factor.
There is a lot involved, isn't there? There are so many things to explore.
There are many, many things to explore. And that's a great point, Sarah, is that it's a complex field. But that was, I think, one of the reasons why I was attracted to this field, because I think it's intellectually stimulating. And on the one hand, and the other hand, the bond that you create with your patients as you help them have a family, it's a bond that's there forever. Mm-hmm. On Facebook, on my texts, when I receive, photos of children and their families and, the happiness. I mean, I just last week from WhatsApp, there's a lovely couple in London who I helped, and they have a daughter now, and a beautiful daughter who's now, I think, 6. And there was just some, during this pandemic time, some photos of them in their backyard, playing, the daughter with the father and then the mom. And those photos just gave me such inspiration. And here was a couple who had struggled with infertility for many, many years, and enjoying a sort of a lovely Sunday afternoon in their backyard, so with their daughter. So, we have to be passionate about what you do in order to be able to do it well.
Yeah, most amazing job to have. It's not really, I mean, job seems the wrong word, but to be able to help create families is so special.
It's very special, and it should be cherished. It's an honor for me to do what I do, and it's great that I always thank and cherish that I have the strength and I have the passion and the opportunity to be able to do what I do. I'm very grateful for that. I'm grateful for that every day.
We think you're truly, truly amazing.
No,
And
thank you, Sarah. Thank you. You're kind.
honestly, you explain things so well, and your passion and your commitment is so clear to see.
Thank you. Thank you. I appreciate that. And I appreciate the time spending with you. And again, if I can help anyone out there achieve their goal of becoming parents. I'm a father of 3 daughters, so 3 teenagers, and of course that's a different story. So if once your children become teenagers, you can come to me and I'll give you some advice, because those are some harrowing times, and some lovely times, but challenging times. But yes, I mean, if I can help, someone achieve their goal of becoming a parent, it's a beautiful moment, and we should cherish it every day. You both do the same thing. You're providing content, you're providing information, guidance, support, and you're helping every day, people achieve their goal of becoming parents. So you should feel great about exactly what you do as well.
Well, I mean, when we started IVF Babble, it was very much just to try and help people where we felt we didn't have the guidance.
Right.
And we are as passionate and dedicated today, 4 years down the line. And thank you to, you and the fertility industry for being able to make families possible. But Dr. D from San Diego Fertility, thank you so much for joining us today. It's been amazing.
Absolutely, my pleasure. And I'm hoping that with, again, as this the pandemic abates, with the hopefully incoming vaccines, that I'll be able to come back and visit with all of you in the UK, and hopefully sometime in the March of next year. I typically come to the UK about 2-3 times a year to see patients and do consultations, and also see some friends and family. So I hope to be able to achieve that in 2021, and I hope that for everyone, that 2021 will be a year that's going to be associated with less suffering, less isolation, less loss. That's a hope for everybody.
Well said.
Well said, for sure.
Thank you. Thank you. Bye-bye. Take care.
Bye, Dr. D.
Bye. Bye, Tracy. Bye, Sarah.